Everyone. Today I'll be sharing with you some of the literature or evidence that I have read regarding this topic, which is the antiplatelet therapy after acute coronary syndrome. So why does this interest me? I think this is because acute coronary syndrome is one of the most prevalent causes of death worldwide, and aspirin has been thought to be the gold standard or the antiplatelet of choice for those patients who had an acute coronary syndrome and who are on the maintenance phase. However, through this review, we will be scrutinizing or learning from those who have studied this space whether or not aspirin is the only choice that we have. Okay, so in this slide, we are seeing that the European Society of Cardiology published in 2023 their guidelines for the management of acute coronary syndromes. So this is a a comprehensive list of guidelines from the symptom identification, from the management, diagnostics, maintenance, prognostics, about the coronary syndrome, acute coronary syndrome. So we'll be focusing on the maintenance phase and the antiplatelet therapy that they have recommended. So here in the graphics that they have made, 6.3, which relates to the maintenance of the antithrombotic therapy after revascularization. So what it describes is that while continuation of anticoagulation after percutaneous coronary intervention is not necessary in the vast majority of patients, that is, those patients without an indication for long-term OAC, post-interventional antiplatelet therapy is mandatory in acute coronary syndrome patients. Following PCI, a default dual antiplatelet therapy regimen consisting of a potent P2Y12 receptor inhibitor like prasugrel or ticagrelor and aspirin is generally recommended for 12 months, irrespective of the stent type, unless there are contraindications. In specific clinical scenarios, the default dual antiplatelet therapy duration can be shortened to as short as less than 12 months, or it can be also extended to more than 12 months or modified by switching dual antiplatelet therapy or de-escalate it. The recommended default antithrombotic treatment options for ACS patients without an indication for OAC are shown in this figure. So this figure on the right recommends the default antithrombotic therapy regimens in acute coronary syndrome patients without an indication for oral anticoagulation. ACS, so these are just the abbreviation and their definition. Also here in this table, you can see that the prolonging antithrombotic therapy beyond 12 months. And here are our options. You can see in the first row, in patients who are event-free after 3 to 6 months of dual antiplatelet therapy and who are not high risk for ischemic risk, single antiplatelet therapy, preferably with a P2Y12 receptor inhibitor, should be considered. Alternatively, the American Heart Association in the same year, 2023, published their own clinical practice guideline. It's the counterpart of the European Society. So here in table 4.3, wherein it lists the medical therapy to prevent cardiovascular events and manage symptoms. 4.3.1, antiplatelet therapy and oral anticoagulation. Here, under first recommendations, in patients with CCD and no indication for oral anticoagulation therapy, low-dose aspirin, which is 81 milligram, or 75 to 100 milligrams, is recommended to reduce antisclerotic events. In patients with CCD or treated with PCI, dual antiplatelet therapy, consisting of aspirin and clopidogrel for 6 months post-PCI, followed by single antiplatelet therapy, is indicated to reduce major adverse cardiovascular events and bleeding events. So on the left also are their corresponding level of evidence from which we can decide which one is best suited for your patient population. In this figure, we have here the recommended duration of antiplatelet therapy. So this provides us a visual on how to go further in caring for our ACS patients. So here are the timeline. On the left, 0 to 12 months and beyond, and the antiplatelet therapy that the AHA recommends. So I would like to underscore this important statement. As an alternative to low-dose aspirin, clopidogrel may be used in individuals who cannot tolerate aspirin therapy, and many of the contemporary trials have used clopidogrel monotherapy after a short course of dual antiplatelet therapy. So this is basically lifted in that specific clinical practice guideline published by AHA. And that leads me to the systematic review that I have searched. So those two guidelines that I just previously mentioned just supports the systematic review that I will be sharing today. This systematic review is published by the authors that's listed in the screen. The authors' names include Liu, Wei-Pan Xu, Hang Xu, Lin Zhao, and Dao Con-Zin. I apologize if I was not able to pronounce their names correctly, but I credit this important, very important work to these authors. So the title of the systematic review is The Efficacy and Safety of Clopidogrel versus Aspirin Monotherapy for Secondary Prevention in Patients with Coronary Artery Disease, which is a meta-analysis. So this work is published in the Frontier Cardiovascular Medicine in 2023, issued in October 2023. So the authors did not have any conflict of interest as they have declared. And here is the URL for those of you who would like to access this piece of work. And we'll just hit the highlights of their work. So the author's introduction is that the coronary artery disease, or CAD, is the main cause of cardiovascular event, including myocardial infarction, heart failure, and cardiovascular death. Antiplatelet therapy is the most important for preventing the occurrence of adverse cardiovascular events for patients with CAD. Aspirin, the first-line antithrombotic drug, has been the preferred use for primary and secondary prophylaxis in populations at high risk for ischemic events for decades. A clinical trial, which is done in US in the year 2018, indicated that primary prevention of aspirin has little or no benefit for vascular adverse events in the healthy elderly population. Instead, it increases the risks of bleeding. Therefore, the clinical benefit of aspirin in patients with CAD needs to be further examined. Clopidogrel, which is an adenosine diphosphate receptor blocker, has been used as an alternative in patients who could not tolerate aspirin or used in combination with aspirin as a dual antiplatelet therapy to provide a stronger platelet inhibitory effect for patients with acute coronary syndrome or undergoing percutaneous coronary intervention. Controversy remains on the use of aspirin or clopidogrel monotherapy for long-term antiplatelet therapy in patients with CAD. The meta-analysis that the authors performed intends to systematically compare the efficacy and safety of aspirin versus clopidogrel monotherapy for patients with CAD. Their materials and methods. Search strategy. They have searched the evidence in English in several databases. The databases include PubMed, Cochrane Library, and Embase databases, and they have searched literature and evidence that were published until March 2023. The search terms that they used are the following: aspirin versus clopidogrel monotherapy and coronary artery disease. Aspirin versus clopidogrel in percutaneous coronary intervention. Aspirin monotherapy in coronary artery disease. Clopidogrel monotherapy in coronary artery disease. Their selection criteria. Characteristics of the clinical trials included in this study include: one is to comparing the effects of aspirin and clopidogrel in patients with CAD. Outcomes reported in these articles included ischemic events and bleeding events. And of course, the articles should be published in English. Other studies were excluded due to the following reasons. Other types of articles including reviews, meta-analyses, letter, and retrospective analyses. They also excluded articles that have incompatible comparison. Sorry. And those articles that have no data available are also excluded. Data extraction and quality assessment. Two investigators independently read the articles and extracted relevant data and assessed the risks of bias. If there was a difference of opinion emerging during this process, the discrepancies were resolved by another investigator. The Cochrane risk of bias tool was used to assess the risk of bias in the included studies. Statistical analyses. Data analysis was performed by Review Manager 5.3 software. Risk ratio with a 95% confidence interval was used to count the effects of each study. Heterogeneity among studies was assessed using the Q-test and I2 statistics, with a cutoff of I2 less than 50% and p-score of more than 0.1 indicates low heterogeneity. P-value. Fixed effect model was used to pool analyze the risk ratio value of each study. I2 should be more than 50% and the p-value should be less than 0.1, indicating significant heterogeneity. Random effect model, or REM, was used to pool analyze risk ratio value. Heterogeneity analysis and sensitivity analysis were conducted. To evaluate the consistency of findings, the sensitivity analysis was by removing every single trial in order from the pooled analysis. P-value of less than 0.05 were considered a statistically significant difference. Identification and selection of the study. Here you can find that the authors identified 1,108 records from the databases. They have screened this number of articles and came up with 949 after they have removed the duplicates. After review of the eligibility criteria, excluded those items that were mentioned earlier, they have come up to 26 relevant studies and finally included 5 in this publication. Characteristics of included studies. They have ultimately included 5 studies. The 5 trials involved a total of 11,766 participants compared with benefits and risk of aspirin versus clopidogrel in patients with CAD. Except for the population of one trial was patients with stable coronary heart disease after coronary artery bypass grafting. The populations of other studies were patients with coronary artery disease after PCI. Characteristics of the included studies. So here is the table which illustrates which those studies are. So we have the first article, which is who the author was, Bath. The second one, who the author was, Koo. The third author was Lemesley. Fourth author was Park, and the fourth author was Woodward. And you can see here the row title include the study population, the length of the follow-up, the sample size, average age of the participants, the gender, clopidogrel dose, and the aspirin dose. Here's the characteristics of the included studies in terms of their quality evaluation as to their risk of bias. So they have checked random sequence generation bias, also the allocation concealment, blinding of participants in personnel, blinding of outcome assessment, incomplete outcome data, and selective reporting, and other biases as well. Let's go now to the results. In terms of efficacy outcome, they look into how this antiplatelet monotherapy affect major adverse cardiac and cerebrovascular events, or MACE. MACE was defined as a composite of death of all causes: myocardial infarction, stroke, and target vessel revascularization. Three of these trials reported the MACE involving 10,102 patients. Heterogeneity among these studies was at a high level. Thus, the random effect model was used to further analyze. The result of full analysis showed that the aspirin group has a similar risk of MACE to the clopidogrel group. To eliminate bias due to heterogeneity, a sensitivity analysis was performed. It was found that the result of one study was the main source of heterogeneity. After removing this study, the heterogeneity became very low, and the pooled results showed clopidogrel could significantly decrease the risk of MACE compared with the use of aspirin. Thus, this result suggested that the use of clopidogrel in the prevention of MACE in patients with CAD is significantly better than the use of aspirin. Here's the related forest plot for those studies, which shows that these articles favor clopidogrel in terms of how this monotherapy of antiplatelet relate to MACE. The next item that they have looked into, the next effect, is the death from any cause. So all included trials reported a death of any cause involving 11,766 patients. Studies were divided into randomized controlled trial subgroups or non-randomized controlled trial subgroups according to the study design. The pooled analyses or subgroup analyses found a low heterogeneity among these trials, and that no significant difference in death from any cause between the aspirin group and the clopidogrel group. Publication bias was analyzed, suggesting that the effect calculating by meta-analysis was consistent with the effect of the intervention in included trials. Here's the graph that they have used, forest plot as well, in terms of how the monotherapy of antiplatelet related to death from any cause. Next thing that they have looked into is the myocardial infarction. 5 studies followed 11,766 patients. 107 times myocardial infarction occurred in the aspirin group and 58 times in the clopidogrel group. Heterogeneity analysis showed a low heterogeneity among the 4 trials, suggesting a consistency of results. They also looked to determine the pooled analysis, and the results significantly favored the clopidogrel group. Forest plot for that myocardial infarction outcome as well. Next outcome that they have examined is the vascular death. Cardiac death was reported in 4 trials. Heterogeneity among the study is 58% with a p-value of 0.07, suggesting a higher heterogeneity. So the effect sizes were combined with random effect models, and results in the forest plot show there was no difference between the 2 groups in preventing cardiac death. Here's the associated plot for the outcome vascular death. Another outcome that they have looked into is the stroke. The stroke event was reported in 4 trials involving 11,582 patients. A high heterogeneity among the studies was identified. Thus, the random effect model was used for combined analyses. There was no significant difference existing between the 2 groups. groups, but one study showed a visible heterogeneity. A subsequent sensitivity analysis was conducted, confirming this study was the major source of heterogeneity. After removing this article, the remarkable heterogeneity was eliminated. The results of the pooled analyses showed a significant difference between the aspirin group and the clopidogrel group, favoring the clopidogrel group. Here is the forest plot for the stroke outcome of those included trials, and also the second forest plot below is after the sensitivity test that still proves that clopidogrel has favorable outcomes in terms of stroke incidence. Next, safety of outcomes. So types 3 to 5 of Bleeding Academic Research Consortium definition for bleeding was defined. So what is type 3? Type 3, we have three types of type 3 bleeding. Type 3A is the overt bleeding plus hemoglobin drop of 3 to less than 5 grams per deciliter, provided hemoglobin drop is related to the bleeding, or any transfusion with overt bleeding. Type 3B is overt bleeding plus hemoglobin drop to more than 5 grams per deciliter, provided hemoglobin drop is related to bleeding. We also include in type 3B, cardiac tamponade, bleeding requiring surgical intervention for control, excluding dental, nasal, or skin and hemorrhoids. Included also in type 3B is the bleeding requiring intravenous vasoactive agents. Type 3C include intracranial hemorrhage, does not include microbleeds or hemorrhagic transformation, it does include intraspinal. Subcategories confirmed by autopsy or imaging are lumbar puncture, intraocular, bleed compromising vision. What's type 4? Type 4 include CABG-related bleeding. Under that, perioperative intracranial bleeding within 48 hours. Reoperation after closure of sternotomy for the purpose of controlling the bleeding. Transfusion of more than 5 units of whole blood or packed red blood cells within a 48-hour period. Chest tube output of more than 2 liters within 24-hour period. And type 5 defines fatal bleeding. Type 5A, probable fatal bleeding, no autopsy or imaging confirmation, but clinically suspicious. Type 5B, definite fatal bleeding, overt bleeding, or autopsy or imaging confirmation. So in their included studies, 3 trials reported this event involving 10,102 participants, and a total of 152 positive events were reported. Heterogeneity among these trials is at a high level. Thus, random effect model was used. The results showed no significant difference between the aspirin group and the clopidogrel group. The sensitive analysis found one article is the major source of the heterogeneity, then this article was removed. They did a second analysis and showed a distinct result. The result favored the clopidogrel group and suggested aspirin could increase the 60% risk of BARC major bleeding compared with the use of clopidogrel. Here's also the forest plot for the major bleeding outcome, which shows that favorable result to clopidogrel. Discussion. The efficacy outcome suggested that the use of clopidogrel is associated with lower risk of MACE, myocardial infarction, and stroke in patients with cardiovascular arterial disease compared with the use of aspirin. The safety outcome suggested clopidogrel could drop the risk of BARC major bleeding down compared with the aspirin group. Moreover, using aspirin or clopidogrel had a similar risk of death from any cause and vascular reasons in patients with CAD. Given that the benefits of efficacy and safety of clopidogrel for patients with CAD is superior to that of aspirin, The authors recommend that clopidogrel be preferred as a sustained monotherapy antiplatelet therapy in the clinical scenario. Guidelines recommend continual treatment with aspirin for preventing ischemic events in patients with CAD. However, the Aspirin trial in 2018, which was conducted in Australia and United States, reported an unexpected result that 100 mg of aspirin daily as primary prevention for ischemic events in older healthy adults had a significantly higher risk of hemorrhage, but did not reduce a significant risk of MACE. Recently, the HOST exam trial in 2021, which was conducted in South Korea, which was the included study in this systematic review, found that clopidogrel, compared with aspirin, could reduce the risk of ischemic endpoint, all-cause death, BARC major bleeding, and any gastrointestinal complications in patients during the chronic maintenance period after PCI with DES implantation, suggesting that clopidogrel is superior to aspirin for secondary prevention in patients with CAD. CAPRI trial in 1996 was the first randomized controlled trial to investigate the effects of aspirin and clopidogrel in patients who had a recent ischemic stroke, recent myocardial infarction, or symptomatic peripheral arterial disease. The results indicated that long-term administration of clopidogrel for patients at higher ischemic risk is more effective than aspirin in reducing thrombotic composite endpoints. Moreover, antiplatelet therapy is associated with reduced perioperative myocardial infarction and bypass patency in patients undergoing coronary artery bypass grafting. Batt and his colleagues in 2011, which was the first included study, compared the use of aspirin or clopidogrel in patients after coronary artery bypass grafting, suggesting clopidogrel can reduce the risk of ischemic composite endpoints, along with the reduced risk of bleeding compared with aspirin. The antiplatelet superiority of clopidogrel to aspirin could be explained by the results of the I Love Mono trial in 2021, which was conducted in Korea, which was the included study number 4, which showed that clopidogrel could lead to better endothelial function, greater platelet inhibition, and lower coagulation activity. A meta-analysis in 2006 of 22 trials for aspirin versus clopidogrel suggested that aspirin increases the risk of gastrointestinal bleeding but no other bleeding. The number of studies reporting gastrointestinal bleeding events in their study was too small to be pooled for analysis. Results from the real-world trial showed that patients taking aspirin had significantly higher gastrointestinal bleeding events than clopidogrel, which may potentially increase the risk of gastrointestinal tumors. More studies are needed to further compare the bleeding risk of aspirin and clopidogrel monotherapy in patients with CAD. The study's limitations include the following. Due to the few trials available to be included in this study, the heterogeneity of some results were high. Although they did not do a second analysis after heterogeneity and sensitivity analysis, the results may have a bias to some degree. The population in the study was a mixed cohort of patients with CAD, including patients with stable CAD who did not receive revascularization, those who completed the standard duration of DAPT after PCI, and those who had undergone CABG. Thus, the authors could not perform subgroup analysis for the diversity due to a lack of direct access to patients' data. Data on minor bleeding and gastrointestinal bleeding were sufficient for pooled analyses because of differences in the observed outcomes of the included studies in this study. Therefore, more eligible studies were required to assess the efficacy and safety of aspirin and clopidogrel for personalized medicine in patients with CAD. Conclusion. Results show that clopidogrel could further reduce the risk of MACE, myocardial infarction, stroke, and BARC major bleedings in patients with CAD compared with the use of aspirin. The findings supported the use of clopidogrel rather than aspirin in patients with CAD who required long-term antiplatelet monotherapy for preventing ischemic events.